abdominal pain, right lower quadrant abdominal pain. We meet here today as specialists of the Eric Williams Medical Science Complex to discuss the case of Mrs. Cynthia Brown. The group consists of the cardiologist, Dr. Kaulasa, the gastroenterologist, Dr. Lavan, and Dr. Rambaran, who is the admitting officer. Myself, I am Dr. Baxton, the internal medicine specialist and the chairperson. Cynthia Brown is an 81-year-old African-American female with a past history of hypertension, diabetes 2, and past history of coronary artery disease. She is presented with lower right quadrant abdominal pain, as previously stated, and we are here to discuss the final diagnosis, or we're here to make a final diagnosis on her case. So I would like to start off by allowing Dr. Rambaran, the admitting officer, to give us more details about Cynthia Brown.
Okay, as aforementioned by Dr. Maxwell, the case we're here to discuss deals with an 81-year-old African-American male, Cynthia Brown, and her presenting complaints include nausea, vomiting, abdominal cramps, no chest pain.
Well, obviously, based on presenting complaint, it has to be GIT related.
Dr. Lavan, let Dr. Rambaran please finish.
No problem.
Okay, well, we saw the appearance of the patient's abdominal cavity with tenderness in the right lower quadrant and no rebound, in addition to positive bowel sounds, were all inconclusive, as these symptoms were indicative of one of many gastrointestinal complications, the most probable being gastroenteritis, diverticulitis, appendicitis, or diabetes mellitus gastroparesis. These symptoms could have also been due to the patient's previous condition of abdominal aortic aneurysm. This would explain the tenderness felt in her stomach, right? The high blood pressure of the patient was characteristic of a patient suffering from type 2 diabetes mellitus and hypertension, as noted in her previous medical history. Her respiratory rate was normal, and appendicitis was eventually ruled out from the 4 suggested conditions, as the patient's history indicated that she had an appendectomy performed many years ago. So, with inconclusive data from these physical examinations of Mrs. Brown, several lab tests were conducted. I conducted a CBC with differential, amylase, and lipase tests, a kidney ureter bladder test, urinalysis, and a CT scan of the abdomen was also conducted. These tests all rated normal, while the CT scan of the stomach showed a dilated stomach. Each of the conditions aforementioned, the diverticulitis, enterocolitis, gastroenteritis, and appendicitis, could have been the underlying reason for this dilation in the stomach, right? So, with respect to measuring the patient's extent of damage done to other organs in the body, a cardiac enzyme test as well as an ECG was also performed. The cardiac enzyme test showed elevated troponin levels, and the ECG was performed just to be thorough. So, with respect to treatment, Mrs. Brown was started on intravenous infusion to treat the dehydration caused by her severe bouts of vomiting and diarrhea, and her spike in temperature, which was 38.8 degrees, and her presence of old renal cysts was also the main reason for starting Mrs. Brown on the antibiotic Zosyn, as she was suspected of having a urinary tract infection as well.
Okay, Dr. Lavan. So we're seeing here that it is leading towards a gastrointestinal ailment. And as such, I would like to hear further what the gastroenterologist has to say. So Dr. Lavan, can you give your take on the case, please?
Well, as I said before, based on this on Miss Brown's symptoms, it must be GIT related.
Not necessarily.
Well, based on his symptoms, it must be.
Excuse Dr. Kaulester. Let us give Dr. Lavan a chance.
Of course.
Thank you.
She's the gastroenterologist here. I'd like to hear from
So, like Dr. Ramran said, it would most likely be diverticulitis, gastroparesis, or gastroenteritis. And just to prove that it must be GIT related, I'll just give a little background into each disease. So, diverticulitis is a bulging of the lining of the small intestine that becomes inflamed or infected, and symptoms related to this disease are usually tenderness in the lower side of the left lower side of the abdomen, bloating or gas, and chills, nausea, and vomiting, all of which Ms. Brown exhibited. Well, most of which. Gastroparesis is a condition that reduces the ability of the stomach to empty its contents even though there's no blockage. And symptoms associated with this would be abdominal distension, hypoglycemia, nausea, premature abdominal fullness, and weight loss without trying, as well as vomiting. Gastroenteritis, on the other hand, is an inflammation of the lining of the intestine caused by a virus, so it's also known as viral gastroenteritis, and it can spread through contaminated food or water. And the symptoms of gastroenteritis include diarrhea, abdominal pain, vomiting, headache, fever, and chills, which Ms. Brown exhibited for her presenting complaints. So based on the symptoms associated with these diseases that I mentioned, her ailment must definitely be GIT related, and more specifically, it would be one of the three that I just spoke about.
Okay, Dr. Laban, your diagnosis are indeed very plausible. However, to make a final diagnosis on this case, I feel I need to hear from the cardiologist. So, Dr. Kaulasa, can you give us your take?
Of course. In any normal situation, in any normal case that presents with lower abdominal pain, I would have to agree with Dr. Laban. However, in this case, I'm not sure.
Why not?
Because it's clearly the body does not lie. I mean, we can miss something sometimes, but the cardiac enzymes that was tested by Dr. Rambaran, the troponin level is usually 0.1. However, in this case, we see it 1.2. That in itself is an indication of a myocardial infarction, a heart attack. If we look at the ECG, now you see, the thing that I like about the ECG is that it is like an autobiography of the heart. Anything that happens, it's there, you see it. Now if you take a look, in this quadrant, we see in 2, 3, and AVF, we see deep depressions of a Q wave. That is another indicator, myocardial infarction. Now you may tell me, myocardial infarction, the patient had no chest pain, the patient had no shortness of breath. How is that a myocardial infarction? Well, we can have two types. The one that is silent, which is ST depression, which we see here in the quadrant V3, or the one where you present to chest pain, which is a STEMI, ST elevated. Now clearly our patient has ST depression, which means that she had a silent myocardial infarction, hence we did not see any signs of chest pain or shortness of breath.
Last time I checked, the patient presented a lower abdominal pain, and to my knowledge, the heart is in the thorax, not the abdomen. So how would you explain that?
Yes.
Of course. Well, Dr. Laman, I can assure you I don't have to review my anatomy. But just to tell you, think about it. We have the colon. Now we have the mesenteric artery in the colon.
Yes.
Isn't it connected to the aorta, which is in the heart?
Yes, it is.
Now, if our patient presented with lower abdominal pain, we see that if the aorta is connected to the mesenteric artery, although very rare, sometimes we see that the embolus, or clot, could travel from the aorta down to the colon, and hence we have this severe abdominal pain. We have this ischemia. Now, it will be silent because it actually happens in the coronary artery, so therefore we would not see any sign, no chest pain, no nothing. And what further shows this is that the patient is a diabetic. Now, diabetics and women, in so many cases I've seen, so many cases that I've gone through, we have no sign of chest pain in diabetics. So that is why I can clearly say from the evidence, although it seems as it's a GIT, it is definitely an MI.
Okay, I have one question. Really concerned, out of curiosity, Dr. Rambaran, why is it that you chose to do the cardiac enzymes examination and tests for an electrocardiogram?
Okay, well, as you know, in hypertension and type 2 diabetes mellitus, there is extensive damage done to the body, especially the heart. So, as there was extensive damage done, the cardiac enzyme test was conducted, and it showed elevated troponin levels. And this was an indication of MIs, as indicated by Dr. Colessa. So, an ECG was also conducted for confirmation and also just to be thorough.
And
Okay, well, that's very good that you
yes,
did that because
it's accidental evidence, and this accidental evidence can actually help to save the patient if given proper treatment. So I think she should be commended for
yes,
it.
Dr.
Yes,
Rambaran, that
you
was
should.
very good. Although it showed to be a gastrointestinal ailment, your decision to do these extra tests proved
Otherwise.
yeah. So, Dr. Kaulasa, as a cardiologist, since we have realized that this is indeed a cardiological propose that we treat this issue.
Okay. You remember from our last, from the file, we have seen, give or take 5 years it was, that the patient had a post-myocardial infarction.
Right.
So she already had one. Now, if you read in the file, it said that there was actually an attempt to place a stent. Now, both stents were unsuccessful because in the circumflex artery, also a branch of the aorta in the heart, and also in the right coronary artery, there was occlusion or blockage. Now, a stent, just to be specific, is usually a small plastic tube. Now, you place it in the artery to open the tube from narrowing, so you have proper blood flow. Now, the thing about a stent is why it's tricky and why it was probably unsuccessful in the prior attempts when they tried, was that you remember in a stent, you're passing the stent through the arm or through the groin, and you're taking this up to the heart. Now, the heart, the vessels in the heart, it's so delicate that one wrong move and you rupture the artery, sometimes you have to do a bypass. Now, that may have happened, that is why the physician probably said it was unsuccessful. However, I didn't see any markings of this in the case, so it probably was not due to the bypass. However, what I could say is that if the stents of a wrong size, normally it is unsuccessful and we actually change the procedure. But in this case, seeing that the patient suffered a second MI after so long, and she's also diabetic, I think we should use the stent, because in this case, we know exactly where the problem is, and I think with the stent, you would therefore also you would narrow the artery, and so you can have the blood flow. So I would say you should reschedule an appointment for catheterization for stent placement, say 2 to 3 weeks post myocardial infarction.
Okay, I will agree with that. And before we conclude, does anybody else have anything to add?
Well, I think I should also commend Dr. Ambrand for being thorough, because I was convinced it was GIT related, but apparently it wasn't. So, congrats, you and kudos to you.
Okay, well, I think we've reached a conclusion on Cynthia Brown's case. I think indeed we can say that it is not of gastrointestinal origin, and it is indeed of a cardiovascular origin, a non-ST elevated myocardial infarction to be specific. This is also known as a silent heart attack. We've came to this conclusion based on the electrocardiogram and the test that Dr. Ambrand requested for the cardiac enzymes. I want to thank you all for coming here today, and we shall make provisions to get that stent in place